see that screen as well. Is that correct? Yes. Very good. Okay. Now for this presentation today, it's not really a presentation, as you know now. We're just sharing some thoughts about the exam rather than really giving any presentation. And what I thought is I will be very focusing on those who are going for the exam in a week time. And I will be very, very specific to try to target some problems that you might face. I am not teaching you cytology now. And for those who has got months till the exam, please try to stay put and silence, because what I am going to do is we are very, very focused on some of the problems that make people fail in the exam, okay? And this is the aim of this session. So I just would like you to bear with me. I will keep changing the screen now because I will be putting some slides. We'll start with the first slide. Let's see the history. The history was that this is a pleural fluid, and the most likely diagnosis, what is going to be, okay, let's see. So this was a pleural fluid, and you will be able to see the full screen now in a second. And the pleural fluid is one of the standard cases that it has to come in the exam. In actual fact, what you will face in a week time, especially for those who are sitting the exam for the first time, you will probably get 2 fluids instead of 1. Usually, in average, you get out of the 8 cases, 2 fluids, okay? And the rule number 1, don't play the fact that the one of them was malignant. You are certain, then this one has to be benign. The second one has to be benign. It doesn't work that way, okay? So if you are one of these gamblers that you tend to try to say, actually, you know what, I did put a 6 malignant diagnosis. So this one I am not sure of, but it must be benign then, yes? And then you're playing the guessing game. This is the worst thing that you can do. What you should be doing in the exam, if you don't know the case and you have the calculation in your mind that you have one case that you were very uncertain of, and now you have a second case which you are very uncertain of, then ideally you should turn both of them into a descriptive case to try to score the maximum mark without gambling. Because if you gamble in 2 cases in the exam, most likely you're going to fail cytology. And you will be miserable for the rest of the 2 days of the exam, okay? Because you have a lot of uncertainty. But what will happen in the exam, that if you didn't gamble and you put your thoughts into the paper, then you have a lot of, instead of knowing that you are gambling, you know that you will score something, and you're probably most likely not going to fail the case. And this is a very important aspect of the exam, okay? Now, when the pleural fluid come in the exam, so we will talk about the pleural fluid for the next 5 or 10 minutes. And I will tell you how we will resolve the difficult scenarios that will happen in the exam. Of course, pleural fluid is one of the difficult cases because you have usually for the FRCPath exam, and of course there will be examples, other examples. I'm not saying that it is this or that. I'm not the examiner here, but I am telling you from the history. And this is what we've been relying on in this teaching. You have 1 or 2 main or 3 scenarios. Let's put them as 3. Yes, so you have 3 major scenarios that you would face with the pleural fluid. Number 1, is the problems between the florid mesothelial proliferation and the malignant mesothelial proliferation, or the atypical mesothelial proliferations, i.e. mesothelioma. This is your scenario number 1. Okay. Scenario number 2 is the problem that we face between the adenocarcinoma and the mesothelioma. So that's scenario number 2. And then we have scenario number 3. And scenario number 3 is the difference between the small cell carcinoma and the lymphoid aggregates that you might find in the pleural fluid. So remember those 3 scenarios, and those are most likely the scenarios which you are going to face in the exam next week, okay, or in 10 days' time. So let's see. The first one is when you have problems with the florid mesothelial proliferations and you're just wondering, is it really a benign or is it a malignant? Number 1, you see, I'm not going to teach you, but I will give you some keys that you need to remember and you need to rehearse in your mind, because these are the things which you probably overread when you were revising, okay? The thing is, there is no doubt in an aspect like that we have a lot of mesothelial proliferation, right? And we know the mesothelial cells, so I'm not teaching you again about the mesothelial cells, but what I wanted you to understand that you have a spectrum, okay? And what we mean by a spectrum, that you have what we will call it a very benign mesothelial cells, that clear one in the middle of your field now, is a very clear mesothelial cells that looks very round nucleus, central. It is absolutely perfect, yes. And then you have a slightly bigger ones, and then some of them have started to acquire this central nucleolus into them with the denser architecture of the cytoplasm. So one of the things is that when you see a lot of benign mesothelial proliferation, or what we call it reactive mesothelial proliferation in the background, then the question which you sometimes raise, can it be mesothelioma or florid? You're most likely asking the wrong questions, because when the aspect is malignant, yes, you can see some transition, but majority of the mesothelial cells in the background are kind of atypical. And atypical means that there is some increase of NC ratio, some variation of the nuclear shape, nucleolar shape, nucleolar sizes, some irregular outlines, and some hyperchromasia. What you see, these are all kind of subtle things that people tend to pass by, and then they start to focus a lot on the actual clusters or the groups that you have in your fields, like groups like this one cluster, and then you start to integrate these clusters more. You see, the other things is when you were in KG1 and people were teaching you the pleural fluid, they tell you the first thing that you have to search for is a second population of cells, because if you have a second population, that means that it's malignant. Okay, but I tend to use a little bit of a different approach, okay? I don't use the second population. I'm dreadful in cytopathology, but I don't use a second population. What I tend to use is to put my baseline and my threshold. And putting your threshold in the exam is very important, right? Just search for what you will accept as normal and what you will accept as a reactive before you jump into the conclusion if this is, I'm going into which pathway. You know, is it adeno versus meso, or is it Floyd mesothelial proliferation versus mesothelioma? You cannot go down that pathway without integrating what you really see in the background as benign or as reactive mesothelial cells. And you need to understand that that spectrum is present in most of the pleural effusion, but it is how much, it is about how much of it is present. Of course, if you get a case of a Floyd mesothelial proliferation, then classically speaking, you will see a lot of benign and reactive mesothelial cells in the background of these clusters. However, the opposite is correct if this case were to represent a mesothelioma, which means that the majority of the cells will be atypical mesothelial cells, and there will be a subset population of reactive mesothelial cells. And obviously, that will create a problem in your mind, because if you did not look at the entire aspect as being abnormal, then you start to develop the impression that you have a two distinct population of cells, and you go to your basic rule because you started to interpret the atypical mesothelial cells as a second population of cells that are not mesothelial. And then you will go down the route or the pathway of adenocarcinoma versus meso, which is a little bit, will be confusing, and your immunotable and your further additional work will be a little bit problematic. So the presence of too many mesothelial cell proliferations, which looks reactive and benign, are very important clue, a very crucial clue into the equation. Now, the people tends to interpret a lot into the clusters of cells, and they wanted to know what I should be doing then, in addition to what you said, Ahmed. Now, you know, what do you want me to do else? Okay, I want you to look, of course, into the individual cell atypia. The other thing is that the multinucleation and binucleation becomes very frequent when the tumors start to become a more malignant of mesothelioma. And this is another thing that you can use when you try to differentiate between mesothelioma and adenocarcinoma, because in the mesothelioma, you tend to have a lot of binucleation and multinucleation. You can get that as well in Floyd mesothelial proliferation, by the way, but we're going back to the atypia, you see. But in the cancer cases, you wouldn't get that, okay? So you wouldn't get these frequent binucleations and multinucleations, that you won't get that. The cases in the exam for mesothelioma, idealistically, what you will find is that you will have a lot of groups within them, clusters. The main difference between the benign or the Floyd group of mesothelial proliferation and the malignant or the atypical mesothelial proliferation is the size of the cluster, okay? Because in the mesothelial proliferations, you can get, well, clusters of 7, 8, 10 cells, 12 cells, okay, right? But if you start to get clusters that are composed of more than 20 cells, when count them actually. Yes, count them. Yes. Oh, do I have time? Yes, because it's a very crucial features. And if you find that the clusters are quite large, you know, you can see there are some clusters here in the middle of the field now. But if I start counting the cells, this may be 8, okay? So you are able to count. You might find a lot of those 8, 9, and 10 cells clusters. But in actual fact, the mesothelial ones will be a little bit or actually more. And this is also another feature that you can rely on to identify. Of course, in what I don't want you to over-interpret is any kind of abnormal looking macrophages in the background, like this big cell in the background. Now you are able to see that big cell in the center of the field with a little bit paler type nucleus, because these are all background drying artifacts into these fluids or degenerate artifact that will make the cells in the background looks a little bit larger, okay? One thing that also irritate the examiners a lot in the FRCPath is that when you say this is a blood-stained aspirin, it doesn't make sense, because majority of the pleural fluid will have red blood cells in the background. And I don't want you to start your sentence by blood-stained aspirate. Just tell me, this is a cellular aspirate. This is a moderately cellular aspirate. This is whatever a pussy cellular aspirate. Just start with that sentence rather than starting, this is a blood-stained aspirate. That's a waste of energy and time. And what do you mean? It doesn't mean anything for me. It's a blood-stained aspirate. So stop using that terminology as well, please. So because we have the spectrum of purely benign into reactive and small clusters into this aspirate, then I have, or I would call this as benign. The other things which you need to understand as well before I move to the next case is that I don't want you to apply the same rules which you use for pleural fluid or acidic fluid against the peritoneal wash, okay? Because what you will have in peritoneal wash, you will have a big sheets of molding cells that they are all mesothelial cells, because when the surgeons do the peritoneal wash at the end of the surgery to ensure that there is no carcinomatosis in the peritoneal acidic fluids, then they use a jet wash. And that jet wash ultimately will result in dislodgement of the entire mesothelial lining of certain segment in the peritoneal lining. And this will end in a very big sheets that will be occupying most of your field. So please, if you are not familiar with the peritoneal lavage, just type peritoneal lavage fluids, and even in Google or anywhere, and see how these sheets of mesothelial cells looks like differently, completely different from what we see, how we see them into the peritoneal in acidic fluid or tap, or in the pleural aspirate, okay? So this completely different ball game. So if it is a peritoneal lavage, there is a big pitfall. Remember that a lot of people will call it clusters of adenocarcinoma or mesothelioma, while in actual fact, because they are big and they are branching, and the nuclear molding and some hyperchromasia, so people tend to call it malignant, irregular nuclear outlines. It can be resinoid as well. but all of those are features of this peritoneal, of mesothelial sheaths in the peritoneal lavage. And after the exam, hopefully for those who would like to continue, we will continue with more applied cytology. Yeah, but this is just one of these things to highlight that about this case. Let me now just move to another case. This is another case here, which I think it was cool as well. The history, as you are able to see it, it is a 51-year-old woman presented with ascites and abdominal pain. By the way, all these slides are available on that website if you take a screenshot now or a picture with your mobile, but I wouldn't recommend that you visit it now before the exam. So don't, okay? Just focus on what you do. So this is why I want, you know, I will not be advising you to do that now. Okay, but I just selected some of the interesting cases from it and we will go through them. This is a peritoneal fluid. Oh, we see the history. Yes, 51, abdominal pain, ascites, peritoneal fluid submitted for cytological examination. Okay, so this is that case. Let me just try to put it in focus for you guys, and we will go through it in some pace here. And then this is now not blood stained. Yes, so you know now not to use that terminology, please. Just describe, go directly to the description. This is a cellular aspect of some sort, and I will just go through it to show you the spectrum of changes which we are seeing into this. So we are hunting, we are trying. And this is one of the problems of the exam, you know? The problem of the exam that if you are under a lot of tension and pressure, so you don't have the systematic approach. Of course, the systematic approach is not what I'm doing now, okay? The systematic approach is to go from one end to the other end, up and down. And this is what you should do, even if you are very tempted not to do that. Please don't. Just don't do what I'm doing now, okay? I'm just doing that for the sake of time, to try to show you more of the problems. And this is basically the cells which we are dealing with. And this is interesting because what you are trying to do now is to try to find any other groups of cells, but you're running out of time and you're running out of cells. Yes, so we kind of like have one or two groups only. You know, there is one here as well, which is very dark and difficult to see what is inside it. So I wouldn't try to even touch it. Okay, so I am trying now to go back to the basics of what I have seen. It's about 3 or 4 of these type of groups, which we did see. And now you don't know. I told you the history was only abdominal pain. This is the real history. We read it together, okay? And you have those, and that's it, right? So any thoughts, okay? Now, I don't want to stress you out, but I just want you to show you an example of the problems that you might face next week, okay? So you are trying and you say, okay, can it be mesothelial? Oh, very unlikely, but yes, because the cytoplasm is a little bit granular, actually, rather than being the cytoplasm that you see in mesothelial cells. The cells are a little bit hyperchromatic, but I'm not sure. Are they definitely malignant, or can they just be reactive sheets of mesothelial cells? Because I told you in the peritoneal fluids, you have to be a little bit careful. Let's try to see one of the other groups, because you can see that it can even be a struggle in the exam. You're not allowed, unfortunately, in the exam setting to highlight the slide. That's a crime, or to dot it, which we do in normal life. And this is one of the problems, that every time you skip the group, then you cannot find it again. And if you're going to find it again, you're spending more time and you're losing time and you're getting more stressed because the clock is ticking, tick tock, tick tock, tick tock. So what is the things is that what I would advise you to do is every time in a specimen that doesn't have a cellularity that is not very cellular like this, every time you see a group, just make your notes on the side of your question sheets. What's your impression about that group? Because you don't want to keep going backward and forward like what I'm trying to do now, to try to find, oh, here we find it. That's the one that I was trying to find. Okay, now then, what is yes, positive for atypical cells and immuno, we cannot write like that. Okay, atypical cells, yes, so it is a problem, isn't it? Because now you are telling me this is atypia, but atypia means that this might be neoplastic or might not be neoplastic, okay? Because atypia can go as also under the impressions of being reactive atypia, okay? So the problem is when you tell me that this is positive for atypical cells, you will not score more than 2. Borderline fail. Okay, so you are allowed to mess up only one more case and you are failing the entire FRCPath exam. Okay, because you are now not going to score the 18 mark that you need to score to pass your or your cytology. You won't. Okay, so the problem is you are allowed one failure, 1.5 in cytology out of the 8 cases, or you can go for a 2 borderline with a 2 score, but you cannot, if you fail the second case in cytology, you fail the entire FRCPath exam. And this is why when you are doing this cytology, a lot of calculations has to be working in the background, okay? Right, let me tell you, the problem of this case was, the main problem of this case is the fact that you were hunting too much for the cells, and you forgot the background. And the streaks, which you are seeing in the screen now, these streaks does not appear on a fluid unless if it is mucoid, okay? And by definition now, if I am to get a cells in a background of a mucoid, in a mucoid background, then this is by definition is a pseudomyxoma peritonei, right? So one of the things is that in this type of abdominal aspirate as well, people are very focused on the fact of benign versus malignant. And in the heat of this, a lot of people will tend to forget that the background is part of your cytology slide. And yes, the background, and this is why people focusing on the blood stained and this debris, that's rubbish. Okay, I'm so sorry, but that's rubbish. This is what is really makes here the difference is inflammatory cells in the background. What type of inflammatory cells do you see? The intensity of those. The other things that makes a lot of difference is this, something like this mucoid background. Since when on a peritoneal fluid you will allow this to happen? We don't, okay? And you might say, well, I'm not very good in realizing mucoid background. Well, this is, you see, in the last 5 or 6 days before the exam, I always advise my registrars and my fellows not to read at all any new information. But what you really need to do, if you don't know what does a lymphocyte look like in cytology, then this is the time to learn it. If you don't know what is colloid look like in cytology, then this is the time to learn it. If you don't know what mucoid means and what is the different shapes and format of a mucoid in cytology, then this is the 5 days to learn that. Any additional information or any new information you're trying to learn will be a crime in the week before the exam, okay? But what you need to do is to look into things like that, and then you will be able to identify this and diagnose it very well. So this is just to highlight this fact, and I wanted you to learn from this case that the background is equally important as the cells. So in actual fact, for me, to diagnose the cells was not particularly important then, because it's not going to make a lot of difference now in these equations or in that scenario. But if you're really eager to see where was the key, in this case, the key was in this little columnar cells that's coming out of the group. It is now in the center of the field. This is a proper columnar cells, and that columnar cells shouldn't be there, okay? And that's telling you that this is coming from an adenoid type tumor or adenocarcinoma style. Either it is anything, you know, mucinous ovarian, mucinous appendiceal, that doesn't interest me here, okay? That does not interest me here. What is interesting for us here, that this is a peritoneal adenocarcinoma, and what you need to say that in the presence of epithelial cells, in a background of mucoid material, are diagnostic of pseudomyxoma peritonei. The scan results in relationship to, if she is a female, you will include the ovarian malignancy. But if this is a male, then you would say the scan results are in mucinous colorectal and appendiceal neoplasm, and additional investigations will be done. Now, the question, good question now, about if I am now thinking that this might be an adenocarcinoma, then how I'm going to play the game of the immunohistochemistry, okay? Let me just tell you the game of the immunohistochemistry for the previous case first, yes? If you decided that this is a florid mesothelial proliferation, so you favor it for florid mesothelial proliferation. Okay, we're talking about the previous case. You remember this florid reactive mesothelial proliferation, okay, which we just discussed. Okay, how I'm going to play the immuno game into that case, the mesothelial florid mesothelial proliferation. I will say that the differential, I said this is favored for, okay? The differential diagnosis usually in this case is those of a typical or malignant mesothelial proliferation. And if an immunohistochemistry, if a cell block is available to perform an immunohistochemistry, then the following immunohistochemistry can be performed to differentiate between a benign mesothelial proliferation and a malignant mesothelial proliferation. Okay, and then you subsequently you will put your whatever you would like to use, EMA and CD15 if you wanted to use them. I think the other commonly used, some people use thrombomodulin, some people also use desmin, and some people use DT40. Okay, but whatever you want, you don't have to put the entire list. If you can remember that membranous EMA is mesothelial and cytoplasmic EMA is benign, so that's a good thing to remember. And then you put your CD15 or desmin, and you're fine. You don't forget, this is only to try to score points. Now you are trying to score points, and then you put your CPC for correlation with asbestos exposure. You do your correlation with the plaques that seen on CT. Are they seeing only fibrous tissue or thickening of pleura, or they are seeing a proper nodularity and plaques, which will go more for a mesothelioma, or like is encasing structures rather than only present on the surface of the lung? All of those can be, but you know all of those sort of things, which you will put an additional information in order to help to score yourself a point. But here, in a case like this, if you want to do immuno, yes, absolutely fine. You can say, I am, if again, I always, when I was in my exam, I always put that sentence. This is how I was taught. I always will say, if a cell block is available, okay, because in most of the labs in England will perform the immuno on a cell block. I know some people use a cytospen equivalent of immuno, but this is limited to very few lab here. But just remember whatever you wanted to say, that's fine. But just say if a cell block is available, additional immunohistochemistry can be performed, and this may include, for example, CT7, CT20, and CDX2, not WT1, because that will be negative in mucinous adenoma for ovarian. But yes, just put that little limited panels and you will be fine with it. And because it is, again, about just scoring points rather than it's a must do. In actual fact, if you get a pseudomyxoma peritonei, you will go directly to your CT scan or your radiology report and see what exactly these patients was presented with. So this is just a little flavor of what might come in a case like this. What I also wanted to share with you is another case, and let's go for another case here, which I find also important. But I wanted to show you how difficult the cases, not difficult, but how misleading sometimes something can be. And let's just tackle this one and see if this is the right one. Yes, that's the right one, should be. Okay, so this is the Pap smear. Now, in the pleural fluid, usually you will be given 2 slides, okay? So you will be given 2 slides to interpret, and then you will be absolutely fine by those. Let me just make sure that this is the right one that we wanted to tackle. Sorry, just bear with me for a second. Actually, the one that I wanted to show you is probably that one. Yeah, that's the one. Yeah, so you have to get used to which one you will be using into the you will be in the pleural fluid. You will be given 2, as I said, the aspirate on the Def Quick, which is that stain, of course, and you will be given the Pap stain as well. You must, and for those who are not used to using the Def Quick and the prefer the Pap, no, in the exam you must use the Def Quick first, because this is how we as a pathologist practice in the United Kingdom. We always look at the Def Quick first, because yes, we know that you can overcall things on it because the cells can be a little bit more blown up, a little bit more enlarged. You can see even the histiocytes, how they are blown up in the background, the macrophages, I mean. You can see the polymorphs are looking a little bit big. Of course, what I am trying to show you now is a different aspirate, because this is an aspirate that has got clusters. Okay, so we have clusters everywhere, as you can see. And I would like you to just don't jump for a conclusion. It's good in cytology to have a first impression. If it is benign or malignant, you write that in the corner of your answer sheet. You say, I think it's malignant. But then you have to try to now dissect the case to prove to yourself that it's not malignant. Yes, because that's after the first impression, right? But if you can convince yourself it's malignant, then absolutely you of course you go for it. Okay, right. You have 2 minutes in the exam, or 3 minutes at the most, maybe 4 for cytology. In the short surgical, I told you you have 2 to 3 minutes. In the cytology, I think you have 4 minutes, because your writing phase is a little bit less. So you would still get the cases in 2 together, right? And if you are lucky, you will get the case as, if you are lucky enough, you will have the easy cases to start with. And this is a pure luck, because in the first minute of the exam, your eyes is not very used to the cytology, because your eyes needs about 10 minutes to adapt to see what's malignant and what's benign in cytology. And if you are unlucky and go the most difficult case in the exam, then you will have to work a lot harder. And to avoid this pitfall, what happened is that you guys will enter the exam station about 10 or 15 minutes prior to the exam to settle yourself down, make your prayers, get your pencils out of the pencil case, whatever you do. Okay, so just I will advise you to do this. Okay, the advice is this is just someone is asking about the history. In this case, the history was 73 non-smoker, history of malignancy presented with pleural effusion. Okay, I didn't make it up, it is just written like that. Okay, so that was the history, nothing. And this is the case that usually, you remember we said that the short surgical history is important and the long surgical, but the history in cytology can be misleading and it is not good to use it. Okay, so I'm sorry, but this is the case. And yes, what I was trying to say, that if you have, if you're going for, to make your prayer in the morning before you leave your house, please. Because in the exam station, while you are sitting and waiting, and people are just giving whatever they are saying before everyone enter into the exam station, your microscope is already there, because in the day before the exam, you will go and set your microscope. Okay, we all know that, yes? So you will set it up in the night before in the exam station. Okay, so you will be introduced to your microscope, or if you're taking your own microscope with you, you are introduced. So what you need to do is you get some cytology slides into your back pocket, okay, or in your handbag, and put your Pap slide and get 4 slides. Yes, 4 slides, preferably urine or a pleural fluid. Okay, so these are the preferable slides to take. So you take those 4 slides, and what I wanted you to do before everyone said, for 3 or 4 minutes, just put these slides and train your eyes on the malignant cells, on the mesothelial cells, on the inflammatory cells, because the initial phase, when you get the first slide of cytology, people, do you know that I would tell you now that if I am to do statistics, majority of the people who fail the exam will fail in the cytology. We know that. And the majority of those who fail in the cytology fail in the first 20 minutes. And that's because your eye is not calibrated, not your microscope. It is your eye that's not calibrated for what's benign and what's malignant. And you need to calibrate your eyes before you see the first case in the exam, or otherwise you stand a very high risk. Please take this advice. Excellent. Some of you said that this is a mucinous adenocarcinoma, okay? And some of you didn't want to comment, and that's absolutely fine. If I was doing the exam next week, I will stay silent. I will not try to give any answers, because I don't want to shake any confidence here, and I don't want to shake my confidence, and I just wanted to stay silent and learn, okay? And this is what I am trying to achieve with you here. I'm sorry, it is just the internet here, my side is slowing down a little bit, and this is why it is a little bit pixelating, especially when I go into the edge. Now, remember this group, okay? Okay, let me just tell you the first things about this group is that I wanted you to tell me if you would consider this group as a large group of 8 or 10 cells, or do you think there are approximately around 30 cells in this group? Yes, just tell me any numbers. Yes, you are allowed to take the slides because you are using them before the exam starts. Okay, as soon as they start giving the instruction and things, you stop what you're doing. And no one will tell you what you're doing because you are calibrating your microscope on a slide. So no one will stop you from using your own slide to calibrate your microscope, okay? So you are allowed, yes, okay? Let's just focus on this for now. Oh, the other things as well that some people tends to take the power, I did that as well in the exam. If your microscope is high-tech, X2, X4, X8, X10, X20, 40, take the X2 off because you don't use that, okay? You don't use that in cytology. And you don't want to waste these 10 seconds of transitioning the slide between X2 to X4 to X10, yes? So please just take the X2 off, and after you finish the cytology, you can always just put it back. So this is another thing that you can do. So, okay, the question here was, do you think this is a 10 group cells, or do you think that this is a big group of cells? Okay, so this is a very important observations in the pleural fluids that a lot of people don't pay attention to, because we tend to look more into the cells, but we don't look into the number of cells inside the groups. So which is another problem. And then the second things that people need to go back to the basic rule of trying to get their baseline. And the baseline here is difficult to highlight. And I'm trying to search for it. I'm trying to search for a mesothelial cells that I will call it a mesothelial cells. And you probably, you agree that this is a mesothelial cells here in the middle of these fields, okay? So if you would take my word for it, and these are mesothelial cells, and you can see this skirt-like periphery, a little bit of two-tone of the cytoplasm. There is a central nucleolus present, and the same here. But you can see there is some variation here, okay? And there is a variation in the size of the nucleus and the cell, okay? But we know traditionally that you are allowed to get a variation of the nuclear size in the mesothelial proliferation. But are we allowed a variation that, like, between those group of cells? Are you allowed to have this 1 to 6 in terms of nuclear variation? Or this is a little bit extreme? Okay, this is number one. Number two, people tend to say, oh, but mesothelial proliferations can be quite large. And if I look into these cells, these cells in the middle of the field now, okay, it's mesothelial again, maybe, but the NC ratio again is quite high actually into this group. Okay, so this is another problems now that we are facing, right? The thing is that people looked into a cell like this when I was scanning this slide, and they saw, oh, look at this vacuole that's compressing the nucleus to one side. This must be a mucinous because it's a signet ring shape, isn't it? Okay, let me tell you that now and take it with you to the exam next week, right? That you are never, ever in cytology to diagnose a signet ring on an individually dispersed cells, okay? Either in the exam or later on in your lifetime career, okay? The signet ring cells in the fluid cytology has and must be diagnosed within the clusters, within the groups. If you go by the individually dispersed cells, that every time you will see a hydropic degeneration in a mesothelial cells or in any cells, you will call it signet ring, even in macrophages. And then you will be calling all your cases cancer, and that will be wrong. Now, the hyperchromasia in these cells are quite striking. And I know that you know that this is okay, it's malignant, right? But now the question is in the exam, and this is the most difficult question, if this is an adenocarcinoma or this is a mesothelial mesothelioma or atypical mesothelial proliferation. It doesn't matter which terminology you will use, atypical mesothelial proliferation, favoring mesothelioma, or just atypical mesothelial proliferation, or mesothelioma, but I tend to use the terminology atypical mesothelial proliferation favoring mesothelioma in the exam setting. In real life, I use only atypical mesothelial proliferation for the fact that it is, to diagnose an invasive malignancy, you have to see invasion in mesothelioma, because there's in situ atypical or precursors for mesothelial proliferation now. But that's not the point. That's not our point here. Our point here is what is, you see, why did I stop by this individually dispersed mesothelial cells? Because I was trying to show you how to build this background population. And what you probably have noticed, that yes, there are some individual mesothelial cells in the background, some of them showing some hyperchromasia, some of them showing very prominent, actually the prominent nucleoli in the mesothelial cells is another big story in differentiating between benign and malignant, because usually in the benign or reactive mesothelial proliferation, yes, you see a nucleoli, but it's usually less than 1/3 of the circumference of the cells. If you start to see more of a bigger one, then that's atypical or abnormal. The other things as well, that the mesothelial cells within the cluster, as you can see, these little clusters, even the mesothelial cells here, or whatever atypical cells, either adeno or mesothelial, they will start show this anisonucleosis, you know, and even the shape of the nucleus itself will start to become different. So these are important things. The things is here, what I am failing to highlight, that there are two distinct populations. Okay, what I think, and some of you will say, no, actually I saw some benign mesothelial cells like that one in the middle, the one that's standing next to the two cells, you know, like that can qualify for a normal mesothelial cell. Do you know what the word population means? Okay, if you get, let's open the dictionary and see. Population means population. Yes, that's a lot, many. Yes, that's a lot of people. Population. Yes, and this is what we mean by two distinct population. The terminology in the textbook, the people talk about two distinct population, not two distinct cells. Okay, and you need to remember that if you are to see then another population of mesothelial cells, that you have to see a lot of these reactive mesothelial cells in the background, that when you take them individually, you do not think that they are actually showing some features and signs of atypia. The problem of the mesothelial cells in general, when they are malignant, that the atypia which we talk about, they are not particularly uniform in every clusters or between every cells. Collectively, you see it in cells. So you will see some cells with a high NC ratio, some cells has got irregular nuclear outline, some cells has got an isonucleosis, some cells has got distinct variation in sizes. So it is, and this is what makes the florid mesothelial proliferations against mesothelioma differential quite difficult. And or adeno versus mesothelioma, sorry, this is what I meant. Of course, some people rely then purely on the shape of the cluster, okay? And they tell you that if the cells, okay, let's just slow down here because we need to go, that you read that in all the textbook, of course. What they tell you, let me try to find a good cluster here so we can stop by it and then try to integrate it. Yes, let's stop by that one. You see, can you see the ending of the mesothelial cells? The beautiful ending of these mesothelial cells in this cluster, you are able to see that. This festooned or skirt-like appearance, yes. So what? But let's not drift. Some people tell you, oh, the mesothelial cells will have the windows in between them, but majority of the clusters, although in theory they should have exaggerated windows, but that's difficult to see, especially with the stress of the exam. But a feature like what you're seeing here is nice. So that one things I see. But the books say that it is the blueberry and the mulberry clusters. Okay, let's forget on these names. Let's try to understand what's really meant by those. What it is in this group, that the mesothelial cells, majority of the typical mesothelial cells will not, the nucleus inside the cluster will bulge out with its cytoplasm. So when you start drawing the festooning around the clusters, you will find out that you have a cell with a cytoplasm inside these festoons. Okay, while in adenocarcinoma, people always say that it's actually not the cells, the cytoplasm that comes out, and it is the nucleus that comes out and indent into the festoon. Okay, so if you still see a rim of a cytoplasm, so let's go to different clusters now. So even in a cluster like this, if you follow the outer boundary, you're still able to find out a little rim around some of these cells. Now, is that a uniform thing? like if I see one cell with a nucleus coming out, then it has to be not a mesothelioma, it has to be adenocarcinoma? No, because you might find one or two cells that it is the nucleus that's bulging out. But uniformly, if I am keep moving now between these clusters and zooming in to try to show you the arrangement, because that arrangement is quite important. And next week, when you have, and I'm telling you now, okay, you will have that situation between the adenocarcinoma and mesothelioma, and you need to be able to sort it out. This is what we call an exaggerated window. Can you see this light zone in between the two cells? This is like a window now, but this is really exaggerated. And this is really what you tend to see into this. This is a multilobulated cells. You see that a lot in mesothelioma. You see a multinucleated, multilobulated nucleus. You can see that they are actually multinucleation, but you see them in top of each other, and they give you that multilobulation pattern. So all of these sort of things you can see. As I said, don't overcall the mucinous or the hydropic degeneration, please. As a mucinous, don't rely on this to differentiate between adenocarcinoma and mesothelioma. This is a mesothelioma case, and what I am showing you, I'm showing you that spectrum of changes within it, and then subsequently, how I'm going to answer this. Yes, so a typical mesothelial proliferation, I'm favoring mesothelioma after you described all the features that you saw. And then the main differential diagnosis in this case is adenocarcinoma, okay? However, the following immunohistochemistry can be used to confirm my diagnosis and my favorite diagnosis of mesothelioma. Just make it clear to the examiner that you favored mesothelioma, but you still would like to get immunohistochemistry to confirm. And who is that clever in this world who will go for a mesothelioma diagnosis without even think to do immunohistochemistry to just stratify the cells? Are they WT1 and calretinin positive, or are they BRAP4 and positive and TTF1 positive, or nevertheless, you don't need to do TTF1, just do BRAP4 immunostain to differentiate. So what I mean is that you still need to score, and you still need to show the examiner that you are a safe pathologist, and you still would like to get the cell block prep, and you still would like to differentiate between the mesothelioma and the main differential in this diagnosis, which is adenocarcinoma, because simply the examiner is not going to enter inside your head, and the examiner is not going to tell you that you know this is you know, to know that you were thinking of adenocarcinoma, and then you will be wrong. Now the worst case scenario, okay, how would I have done that? Yes, so sometimes you say this is a malignant aspect favoring a typical mesothelial proliferations consistent with mesothelioma, okay? Or okay, so if you don't know, if you reach that point that you don't know, okay, then what you can tell me, if you don't know how to differentiate between them, and you never knew what is the difference between an epithelial and mesothelial cells because your institute doesn't do a lot of cytology, or in the day of the exam, you got a black curtain in your eyes and you don't know, okay? So what are you going to do in the exam, okay? At least tell me that this is a malignant aspect, okay? And then tell me the differential diagnosis is between a malignant mesothelioma and a metastatic adenocarcinoma, right? And I am going to do the following table or immunotable to differentiate. Okay, now what it is important as well in this scenario or in this situation, because it might be an adenocarcinoma, okay, but you don't want to lose any extra mark. Okay, so you answer like this, like what I said. So you say the primary panel that I will use to differentiate between the mesothelioma and adenocarcinoma are those. And then in the next paragraph, you will write, if the immunohistochemistry confirms this to be an adenocarcinoma, then what I would like to do is to proceed with for a secondary panel, and that secondary panel will include your differentiation based on the organ. So if she's a female, you say breast, lung, and GI, for example, and then or gynae, and so 4 is enough in that secondary panel table. 3 or 4, 4 ideally is fine, and then you just put the main immuno in that table, which you will use to differentiate, like TTF1, ER, WT1, and for example CK7 or something. Okay, so this is what you really need to do. You are allowed to put primary immunopanel and secondary immunopanel, but when you are not sure now, you probably will still pass the case by 2.5. Okay, but if the examiner is very harsh, you will give you 2. But if you are going to fail on cytology and you said this is malignant aspirate, my differential diagnosis between this and this, you can slightly favor one. That's absolutely fine. About what your instinct feel like during the exam. Is it adeno or mesothelioma? But if you just say slightly favored, at least, you know, I told you there is grading of favoring, strongly favored, highly favored, or slightly favored. Okay, so just say slightly favored, just give it a little push, because it's not going to be a problem now, because what is the examiner will say, of course you will do the immuno, you will know, you will go back to the history, you will look into the CT, you will put all these points in your answer, and ideally they will all of these will help you to be able to reach to pass. It is not about right or wrong all the time, but it is about the approach and how you are going to save the points. You see, you have to play a lot of defense, but you have also to attack. Attack means favor, and you defend by if you have uncertainty, show it, but please tell me how you are resolving it. The history in cytology, as I said, won't be useful and won't be helpful. I think we will have to stop now, but I am happy to give another session, maybe sometimes on Saturday, to continue cytology and cover some difficult areas that come in the exam for those who are willing. If you think that this completely rubbish and nonsense, please tell me now, and I will stop. I am not a great cytopathologist, not good even. I am no one, okay? And therefore, I just were trying to tell you the tips and tricks that you might fail in the exam. I hope that this was helpful. And don't try, and I insist, don't try to use the website, because there are a lot of misleading cases in it. And we have to be selective on what is right and what's wrong. Some of cases are very advanced and very complicated. So please don't use it. And we will stick to the cases which I selected, especially for those who are sitting the exam next week, or otherwise you will hate yourself and you will shake your confidence. I think it is present. Let me just put it again in the front screen. Here it is. It is belongs to the International Academy of Cytology. This is, if you Google International Academy of Cytology and under educational material, they call it IAC. Okay, so this is the website and this is what they have it on. Well, I can't thank you enough for tuning in today. I hope that you find this useful, especially for people who are sitting the exam soon. And I wish you good luck. If you're not able to attend Saturday sessions, wish you good luck for the exam. And hopefully for those who are going to sit the exam, we won't meet again because you'll be able to pass. And this is, I shall pray for you as well from here. And hopefully all will go well. Okay, and by this note, we'll close these sessions and don't stress yourself out, please. Thank you.